Good morning, everybody. Thanks, Dr. Cyrus and Dr. Chan. The problem you find before surgery is the patient's problem, but the one you find after surgery is your problem.
Diabetic retinopathy.
Just a word of caution in this era of fancy intraocular lenses, it's very important to be sure that the posterior segment pathology, even a subtle cataract, exists as a comorbidity in a fair number of patients with posterior segment disorders. Vitrectomy itself contributes to cataractogenesis. Tamponades and adjuvants used in many posterior segment surgeries are cataractogenic, and anterior vitreous dissection is required extensively in some situations. There may be intraoperative lens touch, which also requires attention and leads to a cataract in the early or late postoperative phase. When you are considering a phaco in a vitrectomized eye, it's already also a problem. So combined approach is a better idea, because vitreous support which is not there can lead to unstable posterior capsule that is unusually mobile and flaccid. Vitrectomy may also weaken the zonules, which in combination with a flaccid posterior capsule may allow lens iris diaphragm to move excessively. Fluctuation of the anterior chamber depth can make surgical maneuvers during phaco difficult and can increase the risk of complications like posterior capsular rents, dislocated fragments, with the consequences of CME and detachments. When you're looking at trying to do a phaco in a vitrectomized eye, the posterior capsule may also have occult tears from previous vitrectomy, and a cataract developing within weeks of the vitrectomy should raise the suspicion for damage to the posterior capsule during surgery. Capsular plaques are more common, and they are difficult to remove, fibrotic plaques. And finally, the cataracts encountered after vitrectomy tend to be characterized by denser nuclear sclerosis. Combined cataract and vitreoretinal surgery gives us an opportunity to address both the cataract and posterior segment pathology as a single-step approach. Elderly patients with pre-existing nuclear sclerosis are suitable candidates for combined surgical procedure, and rapid visual rehabilitation is one of the main advantages of this procedure with a single surgery. We have a better visibility of the posterior segment for peeling. There is good access to the anterior vitreoretinal structures. So we do it in patients who have a significant cataract and require maneuvers like membrane dissection, both in the posterior fundus and also when tractional membranes exist anteriorly. In patients who undergo macular hole surgery, there is a high rate of nuclear cataract progression, up to 81% in 2 years, and at least 25% patients will require post-operative cataract surgery. So it's a good idea to combine both together, especially when doing macular hole. Even if you're considering a short gas tamponade like sulfur hexafluoride. 47% have shown progression or appearance of nuclear sclerosis after vitrectomy for idiopathic epiretinal membranes, while virtually no changes in anterior capsular cataract and posterior subcapsular cataract are seen with ERM surgery. In fact, Dr. Eckhart has also expressed this view. In vitrectomy for macular hole, a more complete vitrectomy allows for a larger gas and a longer duration of tamponade, which may improve the closure rate. In diabetics, the advantages are optimum restoration of vision by a single-step approach. Removal of cataract allows better visualization for both bimanual and unimanual surgery. A more complete laser photocoagulation of peripheral retina is achieved in the pseudophakic eye. All the other indications are nearly all the indications for vitrectomy today like all the diabetic complications which we encounter, including vitreous lavage and silicone oil removals, which may be needed in these eyes. Besides ocular trauma cases, retinal detachment repair when cataract coexists, or to achieve a better excision in certain situations, epiretinal membrane surgery and macular hole. The absence of glow and presence of vitreous hemorrhage is overcome by simple capsular staining, and a corneal-friendly surgery with adjuvants is done to protect the cornea. Well, normally the procedure which we do is place the infusion line, or with co-MICS approach we might just go and do a phaco straight away. The IOL is implanted. The wound may or may not be sutured depending upon the stability of the wound itself.
Yes.
And the status of the eye, if it's a very myopic eye or a normal eye.
This is other video.
Wasn't it playing?
And yes. Yes.
Will it play, or do I have to ask you to hit it?
1 second, sir. I'll let you know now only. This will. You have these many slides.
So, in the combined approach, we just, what I personally like to do is just a coaxial micro-incision phaco with a 2.2 millimeter incision, because that allows for most of the acrylic foldable lenses to be used
You can directly
easily.
open your thing.
And
1 second. Yours is just the session. So if you
we go ahead with the 25 gauge or 23 gauge as needed. This was a case of a diabetic epiretinal membrane post panretinal photocoagulation with the persistent macular edema. So simple staining is done after removing the posterior hyaloid, and a peel is done. There might be excessive inflammatory response in some cases, and a shallow anterior chamber may be observed. Excessive aggressive control of post-operative inflammation may minimize these events. Intraocular tampons such as gas also increases the risk of intraocular lens-related complications such as pupillary capture and lens decentration. And these have to be kept in mind in the post-op phase, especially with meticulous positioning and keeping the pupil mobile. Anterior displacement of the intraocular lens may induce a myopic shift in the refractive outcome. I personally like to use the approach of stretching for small pupils rather than iris hooks, because we find them more traumatic, as you see in this diabetic combined procedure with a relatively hard cataract and a very small pupil. Required the simple approach of just dilating the pupil mechanically under sodium hyaluronate suffices quite well and gives fairly good results, and is quite an easy procedure, while with iris hooks and all, the whole procedure is quite traumatic. Acrylic foldable implants are the norm of suture, may be used to stabilize during vitrectomy. The normal viewing system are the wide angles which we use, and just change to landers for some procedures in the macular area. It's a good idea to use anti-VEGFs, especially in combined surgery with diabetics, because if you have with a good intraoperative ablation and a preoperative anti-VEGF, you basically stabilize the disease process well, and risk of rubiosis is decreased, especially in advanced and complicated cases like this with a 2+ nuclear sclerosis along with a tractional RD. Another case of epiretinal membrane was just 2 days post-operative with a combined procedure, an insulin-dependent diabetic with posterior subcapsular cataract with advanced PDR. And macular hole, it's always a good idea to combine. You have a good post-operative picture, and you can even do your OCT on the 4th or 5th post-operative day and see your result. There might be an increase as in any cataract surgery and also in combined procedures, macular edema. There is a controversial aspect. Should a clear lens be removed to achieve full base excision in primary vitrectomy for rhegmatogenous retinal detachment? if there are many cases where a full base surgery may not be warranted, and in every case, so you don't need to do that in every case, and you can just put a additional belt buckle in a very young patient, and you may not need to remove the clear lens in every case. Complications same as any surgery. Thank you very much for your kind attention.